We have several very interesting questions that have come through the question and answer session. And so the first one, I'll put it as an open question because a number of you could probably answer that. And that is related to suicide in patients with COVID. And it's a terrible end to this illness. But I'd like for some of you to comment upon what you think drives people to that. How common is it? What the factors may be contributing to suicide in this population?
I'm happy to start. We had asked about suicidality as kind of a symptom in our study and found that 12% of this cohort, which is mostly non-hospitalized patients, had considered suicide. I think especially for first waivers, we are facing just a complete overwhelming amount of stigma and dismissal, disbelief, you know, for something that is just completely life altering. You know, so many of us can't work, so many of us can't participate in daily life. We see researchers kind of looking in the wrong directions. It looks like our answers are going to come really far down the road. And I think, you know, there's a lot of reason to be, you know, depressed in that way. And I think also there is a neuropsychiatric neuroinflammation component that is also causing these feelings kind of from a biological standpoint.
And I'd like to also concur with what Hannah said. I know last June and July, I was deathly afraid of speaking to the doctors at the hospital I kept going to about my suicidal thoughts because I was already being placed as a psychosomatic patient with just anxiety as my problem. So to then tell a doctor, hey, I have suicidal thoughts, I'm thinking about downing all of these pills, I feared that it would push me into a realm that I couldn't come back from. So I did not share it until this year with doctors that I was suicidal for about a 6-month period. And still today, I still suffer once or twice a month with thoughts of suicide.
Yeah, that's truly unfortunate. Thanks for sharing that with us. I mean, I can share with you that I saw one patient that I remember very vividly. I was an employee here at NIH, and an older individual, never had any psychiatric history. There's no reason for him to be depressed, and recovered from COVID, and then says he got afraid of himself. Says that that he might actually commit suicide, got himself admitted. He had insight into it, so he managed to get himself some help, but it took him a month to get better. So the new onset psychiatric symptoms are also a major problem here, it looks like. Okay, the next question is related to diagnosis of COVID. I think several people were struck by the fact that that the antibodies come back negative. So the question really is that how can one diagnose COVID if the antibody test and the PCR test is negative? Would either Hannah or Athena, would you like to address this?
I really think we need to be including clinical diagnosed subsets at every stage. It just otherwise is going to create a disproportionate, you know, data set toward or a bias against women in particular. You know, we know that women are less likely to retain their antibodies. Like 80% of people who lose their antibodies are women. They have lower levels in general. These tests are just not perfect. So it almost feels in some cases like a medical provider education because we constantly see providers trying to do antibody tests. And in research, you know, what I had presented earlier, we're starting to see that this lack of antibody response might actually be a feature of long COVID. So we really need to include a clinically diagnosed subset and then compare those to the PCR positive or antibody positive. It's really just as simple as that. But what can't happen is that they get excluded.
Yeah. So I think what you're trying to say is that we could develop clinical criteria for COVID. And, you know, for many diseases, we do that where you don't have a diagnostic test. You know, if you have Parkinson's, there's no test you can send out for it, right?
Exactly.
So you have definite, probable, or possible, and then include them as a cohort, right? Okay, thanks. Okay. And then there was one question regarding scores. Has anybody tried to develop a whole score for post-COVID syndrome? My guess is maybe people are talking about scales is what they mean. And would anybody like to address that? My guess is that, for like example, there are depressions, there are scales for subsets of symptoms. I don't know if anything is there for the composite of post-COVID. Athena, you just published some important stuff. What do you think?
I mean, I don't think there is a scale so far. I mean, we are discussing how complex the whole condition is, how multifaceted it is, and therefore, when we are talking about which type of symptoms, right? If it's a symptom spread over so many different organ systems, it's difficult to come up with a kind of a simple one number scale, right, to measure all of that. But on the other hand, there are some efforts. We know, Hannah and I, we are involved in a committee at WHO that we are talking about like the core outcome set, how we can standardize a set of outcome that then all long COVID clinics or GPs basically all over the world can make sure that at least a minimum set of outcomes need to be measured. So we are working on that, various groups are working on that. And as you said, in our study, for instance, we used the standardized scores for various mental health related symptoms, for coping, for fatigue assessment, but it's very difficult to come up with one scale that would capture the complexity of the long COVID condition.
Yeah, that makes sense. And so there's a comment from Maddie Hornig about T-cell responses, and yeah, she says that maybe that's another way. So as soon as those tests become widely available, that may be another opportunity. Certainly, Amit Obar's presentation yesterday highlighted the importance of T-cell immune responses compared to antibody responses in the MS patients who were treated with anti-T cell therapy. So that's another opportunity. Let's take one more question here. So this is that, have any of the panelists observed or experienced helpful psychosocial interventions? Okay, anybody want to talk about that?
I think for the most part, most of us are pretty wary of that, given the history of psychosocial, impact in post-viral illness. It's historically been something that has been kind of misused to redirect biomedical research, misused to kind of focus on the psychosomatic narrative, which is just not the case. Like, this is a biomedical illness. And I think one thing that's really unique about long COVID patients is we are well educated. We have been really building on the work of past activists, past chronic illness communities who have all supported us kind of along the way. And I think we're all really pushing for biomedical research and treatment.
Yeah. So I think it's an important thing for us to discuss, because it is quite often what frustrates most patients, and a number of you have mentioned that yourself, is that you go to a physician's office and they do whatever testing is available to them. Well, this is all negative, and so maybe this is all, psychiatric of some nature, or it's a functional disorder, and that frustrates both the physician and the patient. And it's also true that I've seen patients who truly have a functional disorder, but if you then dig deep in there, there's actually a biological illness there. But oftentimes patients don't know how to really get attention, so they may exaggerate their symptoms a little bit, and the physician is only seeing the exaggerated part, and not really diving deep into trying to find out what the underlying problem might be. So it's a difficult problem. It's not easy for the physician or for the patient, but physicians need to do their part. And when they can't find anything, maybe that's where research studies come in, and research organizations are important in playing a role. And as later in the day, we will talk about all these various cohorts that are being established across the country. Maybe there's an opportunity there for these patients to seek help and participate in studies, and we can learn from them.
Dr. Nath, I'd like to add something too. Yeah. I think, I learned a lot, from you recently when we had a discussion with Body Politic, where you lent a lot of your expertise to that conversation. And what I think also is important, where we could see a change in the partnership between doctors and patients, is if doctors are really, really telling the stories and medical notes that patients are telling, as well as their clinical diagnosis. I can't express how often I had to in the midst of blurry vision and not being able to cognitively comprehend what I was reading, I had to go back and ask doctors to tell, don't tell us a tale of what you think is just happening, but also tell what I'm telling, as well as the clinical diagnosis. And that has been helpful for me. So I would also advise people to check their medical notes to make sure that what is being written about them is as accurate as possible.
Yeah, you're right. I mean, history taking is an art, and
Yeah.
90% of medicine is actually listening to the patient. And that's an important, and how you then narrate the story in your, put the narrative in your own writing is just as important. Nowadays, we have electronic medical records. You have an opportunity for patients to actually look at them. And quite often patients will correct stuff that I've written. I know you missed this. And then we will add an addendum to it. And I think that has actually helped tremendously as well. So you shouldn't be afraid of letting people know. And physicians want to do the right thing. So it's a partnership. Now,
can I add just one note? I just wanted to add that it's actually very unfortunate that these kind of help via psychosocial treatments and interventions has become such a kind of a polarized topic, right? Because I mean, I don't think anybody would kind of disagree that, like, yes, I mean, if you try to relax and meditate, you will feel better. It's not a cure. It was just a help, right? And nobody wants to kind of disagree with that. But unfortunately, what is happening, as Hannah mentioned, that like throughout the history of other post-viral complications, it is replacing treatment. And it is used as a tool to just like kind of gaslight basically the real problems that patients are dealing with, in order to just reduce it to some sort of psychological, psychiatric conditions. And when doctors unfortunately don't have any solution to offer, they then kind of use psychological excuses to just like shut down the patient. And that's a very unfortunate actually story happening, because on the other hand, I really, as a neuroscientist, as a human, as a person who I have meditated many times in my life and I found it useful, I really would like to use that as a tool in my inventory of other things, like coping mechanisms, to use that as well. But it became such a kind of a polarized topic, and which is unfortunate.
I think that's very well said. It's a good adjunctive therapy, but not the sole therapy for a biological illness, right?
Yeah.
So even if you had a stroke, if you do these other measures, they may help you also. That you need other intervention in addition to it.